Today we have a very eminent doctor with us. He is from SGPGI. He is the head of Department of Pulmonary Medicine, Professor ALOK NATH, and he'll be talking us about the ILDs. Sir, so what do you think about ILDs in India? What is the status? Since we have ILD registry with us now, so how do you see ILD, and what suggestion do you want to give to our doctors who are seeing ILD, that how to approach these patients?
Till recent past, we didn't had much of awareness about interstitial lung diseases and how to approach them. With the publication from India, the ILD registry, there is much more awareness about types of ILD, differentiating between various types of ILDs, and because the treatment varies in each kind of ILD, and certainly the prognosis, most importantly, the prognosis is very different in various kind of ILDs. So all the patients of ILD needs to be approached in a very holistic manner. Detailed history with detailed examination, followed by a battery of investigation which includes serological investigations, and not to undermine the importance of getting a HRCT, that is high resolution CT scan of good quality and with maneuvers, that is proning or expiratory films. These all things are very important in evaluation of ILD, and that helps us to narrow down the possibilities and come to a conclusion which kind of ILD actually we are dealing with. And the basic aim behind all this is to differentiate between the UIPs and the non-UIP patterns. The usual interstitial pneumonia pattern and the non-usual interstitial pneumonia pattern. And because the prognosis of UIP, idiopathic UIP, is grave. The mean lifespan of these patients is only 3 years. And rest of the ILDs are treatment responsive, and they fare much well if they are followed up and treated properly. Their prognosis is much better as compared to usual interstitial pneumonia, which is idiopathic, also called as idiopathic pulmonary fibrosis. So the main aim behind all this exercise is to differentiate between various kinds of ILD, especially to differentiate from the idiopathic pulmonary fibrosis, which carries a poor prognosis. And as the awareness is increasing, the outcomes and the spectrum of ILDs in different part of countries from India is also evolving. Till now we have two large publications in which there are stark difference in the prevalence of various kind of ILDs, but still much has to be done. And I'm sure with the advent of various new techniques and availability of all the investigations in various cities, people will start looking at various type of ILDs in a different manner as compared to previous years.
So Professor Alok, we have seen that we are at the research center or tertiary care center, but there are many physicians or many chest physicians who are sitting at the periphery, and they are treating basically the CT scan or the reports. So most of the time we see that the reports are just suggesting ILD. So what are your advice to these kind of reports or these chest physicians, that how to approach ILD patient in that scenario?
Actually, educative programs like this, the conference like this PACS 2018, as a very structured training and programs and workshops should be held both for GPs, the specialists and the super specialists, so that they can be educated in all directions. A radiologist should be aware of what pulmonology thinks like, and a pulmonologist should know what the radiologist thinks like. And if a radiologist's opinion and pulmonologist's opinion, unless they both are corroborated together and put into one thread, and once you elaborate the situation, elaborate the condition or the etiology of the trying to get to the bottom of the etiology, then only it is successful. So the basic need of the hour is to actually hold more educational programs, workshops and training programs for actually characterization and interpretation of HRCT scans, because that is the crux of evaluation of patients with interstitial lung disease. Once you identify the pattern, then only you actually proceed in evaluating these patients to carry out serological investigations and battery of serological investigations, in which too much of unidentified, unclassifiable type of ILDs we come across, and bringing it together with histopathological examination makes it very easy, gives us much ease in evaluating these patients and coming to a conclusion.
So, Professor Alok, as you are seeing so many patients of ILD, the one quick advice that how to follow up these patients once you have diagnosed and start treating these patients, because the patient is continued on same treatment or high dose of steroid. How do you follow up these patients?
The management of ILD is not a one-time process. Management of ILD has to be taken up in a very stringent and controlled manner to follow up these patients in a regular fashion. Once you start the patient on treatment, the patient should be regularly followed for the dose escalation, for adverse effects of the treatment, for assessing the response to the treatment, and the tolerability of the treatment regimen which you have given to the patient. And if at any point of time, after a trial of therapy at first follow-up of 6 weeks, second follow-up 3 months, and then 3 months subsequently, if you feel that patient is not responding to treatment, one should carefully review the whole set of investigation which have been done previously, and evaluate the patient again, so that the therapy may be escalated, changed, or diagnosis may be revised itself. So it's important to follow up the patient very closely, and a close follow-up and a structured program. We run an interstitial lung disease clinic in our institute, and we have a weekly one day dedicated for interstitial lung disease patients, and careful functional and as well as biochemical and hematological parameters, as well as their radiological follow-up is done on a very regular basis, so that we know whether some complications are impending, or some adverse effects are happening to the patient because of the drugs which he is using, or actually the patient is not responding to the treatment at all. So this is very important to understand, that this patient has to be followed up in a very structured manner, and everybody can do it. In fact, it is not so difficult. It is just starting a clinic for that matter. And if you have because the ILD numbers, patient numbers are not so overwhelming, you should have to give some significant time to the patient, so that you can evaluate these patients actually.
So you have your talk on lung biopsies in ILD. So just a key message, that which patient require lung biopsy in ILD?
We had a very interactive and very interesting discussion on requirement of biopsies in various kinds of ILD, especially in patients with usual interstitial pneumonia, which American Thoracic Society recommends that in patients with definite UIP pattern or HRCT, biopsy is definitely not required. But in patients with possible UIP pattern, according to ATS, biopsy should be done and alternative diagnosis should be sought for. But a recent paper in Lancet challenged it view, that is the Fleshner Society white paper in 2017. They had actually segregated the possible UIP into 2 groups, making it as probable IIP and indeterminate UIP. And that is where the only point which actually Fleshner Society took into consideration was absence or presence of traction bronchiectasis. And that was the group where Fleshner Society says yes, biopsy may be done. But they have been lenient on that part to, for those patients who have probable UIP pattern, they can be treated like UIP, considering them as IPF, which doesn't seem to be very appropriate to me, because several studies and several case reports are there in which a possible or a probable UIP pattern has actually, when examined histopathologically, has not shown classical UIP pattern. And labeling somebody as IPF, as I told in my opening line itself, it carries a grave prognosis, and it's almost like a, you are writing off that patient, that his median survival only is 3 years, and giving somebody a grave prognosis and a very dismal prognosis and a diagnosis which does not have much, there is nothing much to do in the from the therapeutic point of view. You should be very careful in doing that. Therefore, my suggestion is that wherever in doubt and you have atypical features of UIP and patient is fit for biopsy, do it early. and do not try something on that patient, it doesn't respond, then do biopsy. Rather than doing all these things, you should consider those patients for biopsy in early phase when the patient is fit to undergo any procedure. Whether it may be a cryobiopsy, cryo-TBLB, or it may be a VATS guided biopsy, that is up to the patient's fitness and the patient's choice to undergo surgical biopsy or to undergo bronchoscopic cryobiopsy.
Thank you, Professor Alok Nath, for talking to us and being a part of PACS India 2018. Thank you very much.